Okay, so just a couple of cases to illustrate some key themes and points from the day, all of which have been subtly edited in case anyone is here. So we have a young 35-year-old woman, totally healthy, presents with some abdominal pain to an outside hospital. It's primarily epigastric, right, so around the belly button and radiating to the back, and she presents with nausea and vomiting. And fortunately, the laboratory studies are largely unremarkable, a little bit of elevation in the amylase, a little bit of elevation in the calcium, but pretty bland. And so we perform some imaging, of course. And so what I wanted to do is try point out for the audience, right? So we have a couple of lesions here. So we have a large cystic lesion in the head of the pancreas with a dilated duct back behind it. And then on the bottom cut, we're able to see a second, and you'll notice this actually points to Dr. Loyer's point, right? So we have another tumor in the tail of the pancreas with totally different imaging characteristics than the first tumor. So I wanted to quiz our pancreas experts on the panel. Do we start to have a differential diagnosis based on the particular imaging characteristics that we see here?
So, as Dr. Loyer would say if she was here, there's different imaging characteristics or different imaging findings are characteristics of different types of tumors. And when we see tumors in the pancreas that light up with contrast, the way that one that he's pointing at does, we immediately think of neuroendocrine tumors. What else could that be? There's a few things that light up like that when you see a blob in the pancreas. There's a few other things it could be. They're pretty rare. Things like, spread of melanoma looks like that, spread of breast can look like that, but 99% of the time if we see something that looks like that in the tail of the pancreas, then we're thinking neuroendocrine tumor. In contrast, that thing in the head, while would not be as characteristic, actually. The way it's darker in relation to the rest of the pancreas is not entirely characteristic, at least of a low grade 1 or 2 neuroendocrine tumor. Things can look different ways, but I would not say that is entirely characteristic. It's difficult for us to give 2 different diagnoses to one patient. We try to avoid that. But in this patient, if the first time you look at that scan, you'd say, wow, those look like two very different disease processes.
I think one of the component may be confusing in the darker part, maybe some obstruction to the pancreatic duct. That may be a component to it. It's tumor plus.
Yeah.
And how high was the calcium?
Not that high. I think it was about 10.7 or so.
10.7 with a normal phosphorus and PTH.
Yeah,
okay.
for now. We'll get there. That's the hidden gem in the case. How about next diagnostic steps? Does anyone have any preferences on how we might approach this and why?
So typically we would get an endoscopic ultrasound, so they basically... Typically we would recommend an endoscopic ultrasound. So this is a type of test where you may have had a colonoscopy in the past, where they put a long flexible tube through your anus to look at your lower GI tract. We can also do that through the mouth. And instead of looking at it with with your eyes, you can attach an ultrasound probe to that flexible endoscope, locate the pancreas, and then through that flexible endoscope, put a needle through the stomach or small intestine into each of those tumors or blobs or whatever you want, imaging abnormalities, and actually suck up pieces of tumor for analysis. And so because we can actually get a tissue biopsy with that approach, that would be the standard approach.
Yeah. Is there a reason to prefer that over an interventional radiology approach, sticking a needle, I don't know, through there to get there from the outside?
Typically we favor an endoscopic approach because the needle is put in through the stomach or small intestine, there is very unlikely, but not unheard of, typically with other cancer types, risk of seeding along the needle tract, meaning when they put the needle through your abdomen and pull the needle out with tumor in it / on it, you can leave little bits of tumor that then contaminate the abdominal tract. I personally have seen that once. It's really, really uncommon, so I don't want to scare anyone, but for that mostly theoretical reason, we typically would use an endoscopic approach.
All right, so a diagnostic procedure is performed. They do an endoscopic ultrasound, and so we find 2 tumors, right? So we have a grade 1 neuroendocrine tumor in the tail, and then in the head, they have a separate biopsy. They have some scant neuroendocrine cells that can't be graded, but it looks like cancer. They both have chromogranin and synaptophysin. So now that we have this tissue diagnosis, do we have some preferred imaging studies we might advise? And are given sort of the constellation of findings that we're seeing in this patient, Dr. Chun, are there any additional specialists we might want to call?
So this is a non-functioning pancreatic neuroendocrine tumor.
2 of them, yep.
So for non-functioning pancreatic neuroendocrine tumors, it's very, very unusual to find multiple tumors if they're not associated with MEN1. So I would work that up.
Right, so we'd want like an endocrinologist or a geneticist or someone who's familiar with MEN1 in the setting of multiple concurrent pancreatic neuroendocrine tumors, which was why I fudged the numbers and told you the calcium was a little high, even though in the original case it wasn't. Any other imaging studies we want?
I think, you could just, what I'm saying is if you're going to order test, if you're going to do order any, I would say order a TED. The reason I would say that is it gives you a whole body staging, and if you have a grade 1 tumor, that's the best test, and it can show lesions anywhere from 2 to 3 millimeters above.
One question to ask is, did you only see 2 lesions in the pancreas? In that one situation, often you may see a lot more than just 2. In other situation, we see this is metastasis to the pancreas from a small bowel primary, so another reason potentially to complete the imaging studies.
Mm-hmm. And I would just say if this patient had been seen here at this time, that study would have been performed because this was an outside case. Yeah. Instead, they proceeded to the next therapeutic step. Is there anyone on the panel who might focus on therapeutic steps for masses in the pancreas who wants to comment on what they would do here?
What was the question?
What would you do?
What would you do?
Oh.
I can draw a line. I don't know how.
So with respect to surgery is certainly possible. When as these other panelists have mentioned, having more than one neuroendocrine tumor in the pancreas is relatively uncommon outside the settings that they described. That is a genetic syndrome or metastasis. In these uncommon situations, we typically are relatively conservative, actually, because as it turns out, particularly in the genetics syndrome that was discussed, they don't behave as aggressively sometimes as you might think, and we don't like to remove a lot of tissue of the pancreas unnecessarily because you can have problems associated with pancreatic loss over time, et cetera. So we sometimes take a very conservative approach in that situation, and we typically would operate. There are relatively flimsy guidelines, but we typically operate when a tumor is, larger than 3 centimeters as one commonly cited guideline. In this particular case, I think it may or may not be reasonable to remove both of these lesions. To do so would require removing about 2/3 of the pancreas. If we did that, we would want to have, as Dr. Yao said, really done a good workup to make sure we're not leaving anything behind. Not because we wouldn't want to leave it behind, but we would want to know, for example, what if we did a distal pancreatectomy, we removed 2/3 of the pancreas, and there's still something in the head that actually grows fat, is the thing that's going to grow and cause problems. I would actually, want to get to know that patient a little bit better, maybe not rush them to the operating room right away, follow them for a short period of time, just to make sure that there's not changes in other tumors that we might be leaving that might make us second guess whether we want to remove the tail of the pancreas, if that makes any sense. So, long story short, surgery could be done here, but I personally would make that decision over a couple of visits.
Yeah, so a couple considerations. You really want to know whether you're dealing with a genetic cancer syndrome or not in this situation, because if you're dealing with a genetic cancer syndrome, the underlying genetic abnormality is in every single cell in the body. It's not something you can, solve by operating or any sort of resection. Another aspect to consider here is the symptoms patient's having, the abdominal pain and so forth. Does the patient have chronic pancreatitis from the obstruction of the pancreatic duct, and how atrophy is essentially the tail? It's a relatively young patient. The tail looks actually a little bit smaller than usual. That can essentially tell us how likely the patient's going to end up with brittle diabetes and that sort of issues afterwards.
Any other comments from the panel?
I agree. I think the long story short, what you're hearing is there's not an emergency here. So, I want to emphasize that for this disease process in general, and cancer in general. Cancer is very uncommonly a surgical emergency. And if you feel okay and you are being told that you need to go to the operating room tomorrow for your cancer, get a second opinion. I think that's probably, as a surgeon, the biggest thing I can leave you with.
So this patient went to the operating room and had both tumors removed as what would we call that, sort of a mid to distal pancreatectomy, that's sort of right, because they left the head and removed the rest. So as predicted by our panelists, so the tumor in the head of the or towards the head of the pancreas was a grade 2 neuroendocrine tumor with a Ki-67 of about 8%. That invaded out of the pancreas into some of the peripancreatic soft tissue, but not the adjacent organs, but none of the lymph nodes were involved. The 2-centimeter tumor in the tail was sort of a pure grade 1 neuroendocrine tumor, and as predicted, there were multiple little sub-centimeter microadenomas along the way, which, as Dr. Yao alluded to, is highly, highly suggestive of multiple endocrine neoplasia, and in fact, that is what this patient turned out to have. So the multiple pancreatic neuroendocrine tumors, the multiple microadenomas suggested a genetic syndromes. The patient did see a genetic counselor and was diagnosed with multiple endocrine neoplasia. At the bottom, I've tried to summarize the multiple different staging systems that have been proposed for pancreatic neuroendocrine tumors. Would anyone like to comment on the various staging systems that have been proposed and how we might think about this for this person?
I think people a lot of time creating complex staging system just so they can publish papers. And they keep changing the system so they can keep publishing new papers. The question really here is, how will any of the staging data drive therapeutically what you're going to do now? And, the information I think that's important is that it's no negative. But beyond that, because, unlike in colon cancer, we use the stage to drive whether we do adjuvant therapy. We actually don't do that here. If it's completely resected, we don't do that. So I think it's needlessly more complex than it needs to be. I think, Matt, you probably can comment, even the panc-adeno staging system sometimes is, you kind of have to question.
Yeah, I don't, patients ask me what is my disease stage, and I don't say this flippantly, but I say, look, the staging system for pancreas cancer particularly is not very important. I can tell you all the clinical information that you need to understand. I understand the desire to know what stage, but sometimes just hearing the, the clinical understanding the clinical situation, really what is making up the number or the letter or whatever they're using
Right.
is more important to understand than having just a number and a letter.
And so you'll notice that's what basically happens between these three stages, is we just shuffle all of the variables around and get sort of the same things. The question I thought was interesting to pose in the context of those three different staging systems is, can anyone give an estimate of what the recurrence risk of this kind of tumor would be? Because that's...
So, I mean, I think this is a tricky question.
Yeah.
It's a tricky case. I
I'm
would
trying
say,
to put you on the spot, Dr.
yeah,
Yao.
so I think the recurrence risk is 100% because we're dealing with MEN1. There's a risk of new tumors developing de novo in the remnant pancreas. There's risk of lung carcinoid tumors. There's risk of thymic neuroendocrine tumor. The reason I say that is this is not a case where you can say, oh, we're going to follow for a fixed number of years and we're done. Because if it's MEN1, we're going to have to always keep looking at it.
Yeah. And you touched on this, but how about adjuvant therapy, Dr. Yao? So in other words, should we give any treatment after this surgery to ensure that this patient's cancer, or to minimize the risk that this patient's cancer comes back?
So there's no data for adjuvant therapy here. Even though there's a risk for, I would say even go broader, I would say there's no data for adjuvant therapy for any low to intermediate grade neuroendocrine tumor. Even when there's a risk of relapse, there's no data to suggest any sort of treatment you would give actually reduce that risk of relapse. So, so in short, no. There are people who ask questions, should I do some mass analog, should I do PRRT? Absolutely not.
Yeah, I would agree with that because since there's no data to adjuvant therapy, there's no point doing it. That's I firmly believe.
And so how would we start to think about surveillance from the perspective of the resected tumors? We don't have to get into sort of MEN1 monitoring, but from the perspective of these tumors that just came out, how would we think about monitoring for distant disease?
So, as a radiologist and a nuclear medicine physician, I have a very firm sort of public health concept on this. Many institutions, including ours, do scans when the patients come back to see the clinical colleagues every 6 months or every annually. Whenever they come, you do a scan just to make sure there's nothing has come back in the interval time. But not only just neuroendocrine tumors, as a policy we say, or as a public health policy we say, there's no point doing scans unless there's a clinical question. Sure, that would reduce the number of scans you will have, because we do not think detecting a tumor maybe 6 months earlier will really change your overall survival. It would change your management, no question about it, but it's purely due to the lead time bias that comes into play. So that's just a general policy, and Dr. Jha might have a different thought.
I think those are really good questions, but I don't think we had an answer to those questions. I think lead time bias could be a part of it, but we don't have proof that the longer survival is due to lead time bias. I think a number of our surgical colleagues would argue that sometimes these tumors do recur in a way they're amenable for complete resection. In many cases, after a second round complete resection, the disease will recur again. But there are a few cases where the patient live out a natural lifespan without recurrence.
From our surgical data, the best data that we have is pretty outdated, but it's good. It's from the NIH, and it's from the 1990s. And for MEN1 patients, the determinant of their survival was the presence of liver metastasis. and that seemed to correlate with 2 centimeter size in the pancreas. So one, I would do surveillance for his liver, and then for his remnant pancreas, he's going to recur at some point in the pancreas. And again, when it reaches that critical 2 centimeter threshold, in the absence of better data currently, I do think it's important to monitor the pancreas also.
Another point in that, same, I just want to say is, as far as the imaging test is concerned, we can have a CT, you can have an MRI, you can have a DOTA-TET PET CT, you have 3 different studies you can have. Are you going to have all 3 of them? Or are you going to pick one of them? It's a real important question. The reason I say that is identifying, I don't know how this is going to play out in real world, since DOTA-TET now can identify less than even 4 millimeter lesions. It's going to be an unknown field we are walking into, in my opinion. In the sense, like I had a patient last week, had a neuroendocrine tumor, treated, disease-free for 4 years, and then they picked up he has been monitoring every 6 months with a liver MR, and picked up a small 1 centimeter lesion. They thought I will monitor that. So he comes back after 6 months. So they picked up a 1 centimeter lesion, and he comes back 6 months later, have another scan. And here now that 1 centimeter lesion hasn't changed. And then there was another 4 millimeter lesion just appeared somewhere in the liver. So the question was, what is this second lesion and what's happening? So they ordered a DOTA-TET PET CT. And the patient had almost 50 lesions. That just brings up a really challenging question to us, how we would sort of surveillance, how we would image these patients. If you just did a CT, and you may say you don't have any disease. If you did a DOTA-TET PET CT, you may have 3 or 4 or 5 lesions. So it's a challenging area that's coming into clinical practice, so you have to be watchful.
And that's exactly where the case is going. So,
So yeah, these are really great. It's a really good case. So the question also is, how frequently do you follow these patients, and how frequently do you scan? These are not like big randomized trial where it said if I scan patients, once a year versus every 2 years versus every 6 months, there's a difference in survival outcome. So to some extent, is still in the realm of expert opinion. Rightly, wrongly, what we do is probably we at least do once at the 6 months interval after resection, and if everything goes okay, we probably push that out to once a year or something like that. We probably scan people more than they need to, but those are really good questions. But in terms of DOTA-TET versus anatomic imaging for scanning, I think this field is going to continue to evolve. But one argument could be made that, I probably would not do DOTA-TET scan for the purpose of surveillance. Because if you detect things that has no anatomic correlates, meaning you detect lesions that are so small that you can't find it on anatomy, and the surgeon can't find it on, can't point to what they're going to do with it, then it becomes questionable. It's like, what do you do with that piece of data? And people think, well, it's always true initiation of treatment earlier leads to better outcome. Actually, we assume often that's the case, but that actually may not be the case. Example I would give is the data from the study with Lanreotide, Clarinet study. It clearly showed, compared to the placebo arm, the time to tumor growth was better on the people who got treated. But there's no survival difference between the 2 arms. That's because the people who were on the placebo arm, when they did have tumor growth, they were able to get their treatment later. So the comparison in terms of survival perspective is early treatment versus late treatment. Treatment right away or treatment when there's tumor growth. in that particular trial, they showed actually survival was actually the same in both arms. So I don't think it's a automatically conclusion that, detecting the lesion earlier, is going to lead to better outcome.
But I think where this would play out is if you have a liver that has 2 lesions, and then all of a sudden we identify an abdominal lymph node, 2 abdominal lymph node, so no longer your disease is just localized liver disease. It has gone, the disease is beyond liver. So then decisions about management are made about those lesions. It has to be thought out as a more comprehensive way than just a focal way.
The question is, though, how clinically relevant are those tiny little lymph nodes that are picked up?
Yep. I think it would be, that's the most important. What would be the outcome difference would be?
Right. So
I wouldn't say you can just wait until the patient becomes symptomatic before we check either, because as many of you guys know that often patients are sometimes not symptomatic until 50% of the liver is replaced, and that's not a good place you want to be. You have very little margin at that point. So somewhere in between, I guess.
yeah, so it's a fantastic discussion, I think, moving back and forth between, on the one extreme, sort of if this tree fell in the forest and there was no one there to see it, would anyone hear it, right? If we detect insignificant lesions that we never otherwise would have, do they matter? Versus maybe we should wait all the way and perhaps the truth is somewhere in between. So that was actually just the point that the rest of the case was meant to illustrate. So we can actually skip to the second case. So now we have a 45-year-old woman, again, very healthy, this time with some nausea, vomiting, and abdominal pain. But on history, she actually has a more subacute story. She tells us that over the past 6 months, she's been having this sort of colicky abdominal pain after she eats. She's lost about 30 pounds in this time, and says, doc, come to think of it, over the last maybe 5 or 6 years, I've just had sort of a sour stomach. Laboratory studies are generally unremarkable. Her albumin is a little bit low, is actually pretty low at about 2.5, and just a compensatory hypocalcemia, but nothing actually abnormal in relation to the albumin. And then, of course, perform a CT of the abdomen and the pelvis to evaluate her. And so here we see what we would see. And so what I've presented are just the 2 different ways that we can localize this lesion. So here we have a nice calcified lymph node next to a pretty significant abnormality in the bowel. And then what I've tried to do actually is, I had to scroll back and forth to the panel to actually find this, but this is the closest thing to a transition point that I think we could identify, where we had some dilated loops and then things get pretty edematous and swollen, and the contrast just sort of sneaks through over there. And this is roughly in the same place, plus or minus. So I'm just trying to describe to the panel that what we have here is evidence of sort of incomplete small bowel obstruction, and we see next to that this calcified lymph node and a lot of swelling in the wall of the small bowel. So this is sick bowel. And then if we look actually down in the pelvis, we're going to notice that we start to see these other abnormalities. This is disease in the peritoneum, that potential space between the organs and the abdominal wall. And we don't have good visualization here of any abnormalities in the liver, but perhaps more on that later. So having a difficult time getting to the lymph nodes, a biopsy of one of these omental nodules is performed. It reveals a grade 1 well-differentiated neuroendocrine tumor with a Ki67 of 2%. And again, it stains positive for synaptophysin and CDX2, which is a classic sort of small bowel midgut marker. Okay, so to the panel, the operative question of the day: are there any diagnostic tests we might want to perform in addition?
I think there's lots of diagnostics that you could do, but I don't know whether it would ultimately change whether the patient needs to go to the operating room or not. Here, there's a clear symptom indication, partial small bowel obstruction. But I'd love to hear from our surgical colleagues. In adenocarcinoma, in someone who has peritoneal disease, our enthusiasm for operating tends to be not as high. But what about in neuroendocrine tumors?
Right, so I completely 1,000% agree with Dr. Yao, as usual. But the issue here is that I was talking in my talk, there's multiple reasons we can offer an operation. And the reason to operate here is palliation of symptoms, meaning make those symptoms go away. We don't often operate in the setting of disease spread to the peritoneum as exists here with other diseases, particularly other diseases that I treat. The reason for that is when patients with other disease have disease spread outside and throughout the abdomen, their lifespan is typically severely limited. In this particular case, in the case of low-grade neuroendocrine tumors, you can have sometimes relatively significant disease spread to the peritoneum in the absence of a significantly curtailed lifespan, meaning patients can live quite a while. And I would not want this particular patient to live in, sounds like, significant pain. So I agree with Dr. Yao. What if we did a toe-to-tape scan and found something in the liver? Operate, right? Because we want to fix the symptoms at least. The goal here is not cure of disease. She's still going to have cancer, but at least we can help her and make her feel better. So I agree. I wouldn't. I mean, you can get other tests, but she still needs an operation. Yeah.
Right. And so while this patient's awaiting an operation, a gallium scan was performed, which lights up actually the exact same area of the small bowel that we were looking at, the disease that we pointed out down in the pelvis, and also we start to see some of these liver lesions that pop up. So we have some low volume but disseminated hepatic metastatic disease, as well as that pelvic peritoneal disease in the adjacent mass. So I think we've touched on this. So how would the panel approach this? Surgery right away, this patient with 30 pounds of weight loss, how would we think about it?
Yeah, I'd operate on this patient for
Okay.
sure. Lifespan anticipated to be long, potentially. A lot of options for this patient. And are we going to cure the patient with an operation? No, but a lot of weight loss, patient not able to eat very well, a lot of pain. We can really help this patient, and the patient's eligibility for other treatments may improve because her health status may improve because she's feeling better.
Okay. And Dr. Chun, may I ask you, so it sounds like there's an urgent need for a bowel operation. In the big picture, I've tried to give you a sense of the distribution of disease in the liver. I think we have a bit of a sense from the two different views here. How would you start to think about, say, after that bowel operation, thinking about liver resection in this sort of situation?
So classically, extrahepatic metastasis would be a contraindication to doing a liver resection. With gallium dotatate PET, things may change because it's going to pick up a lot more extrahepatic metastasis that we weren't aware of before. And so then do you automatically rule out surgery in that situation? I don't think so, but this is anatomically visible peritoneal disease, so I would not offer liver surgery.
What was the answer? I'm sorry, you trailed off at the very end.
Oh, I was just saying that in her situation right now, she has on CT scan visible peritoneal disease. So I would not do liver surgery at this point.
Wouldn't remove the liver.
No. Mm-mm. She's also malnourished, and so she needs to get her primary problem fixed.
Yeah. So those are really actually all. This was a shorter case, just meant to bring up all of the points that you all just did exactly as I had hoped. And I think this is actually a great place for us to stop and move on to Elisa's final remarks. I just want to thank the panel for the fantastic